Okay, Dr. Rayford here, Vet Triage. We're going through November 2024 edition of Veterinary Surgery. We were talking equine this time, equine wounds. So, preliminary in vivo investigation of the mesenchymal stromal cells secretome as a novel treatment for methicillin-resistant Staphylococcus aureus, which is MRSA, in equine skin wounds. This is similar to the study we had on beagles from this edition. This study comes out of Cornell University. Whoop, whoop. Objective, we aim to study the antimicrobial and pro-healing potential of equine mesenchymal stromal cells secreted products, they call it secretome, collected as conditioned media from mesenchymal stromal cell conditioned media in a novel in vivo model of MRSA with horses of thoracic wounds. It's a prospective in vivo study, so in vivo meaning in the patient. They used 2 thoroughbred geldings. They created 6 full thickness cutaneous wounds bilaterally on the dorsal thorax of the 2 horses, so 12 wounds per horse. Inoculated MRSA on the wounds on the left side. All wounds were treated with either mupirocin ointment or the mesenchymal cells or a vehicle control, so 4 wounds per group. Once daily for 3 days, they were treated with these modalities. Results found that inoculated wounds had more bacterial colony forming units at day 1 and were larger in size at day 28 than non-inoculated. Mupirocin wounds were smaller than mesenchymal and vehicle controlled wounds by day 28. Mesenchymal stromal cell conditioned media did not affect the colony forming unit numbers in inoculated and non-inoculated wounds. Moreover, mesenchymal treatment did not affect the parameters of wound size or gross or microscopic wound scores over time. Conclusion, mesenchymal stromal cell conditioned media did not exhibit antimicrobial or pro-healing properties in the current study. However, in the in vivo model of inoculated equine thorax wounds requires further optimization. Introduction. Traumatic wounds are the second most common emergency in equine medicine. Infections are a problem. Staphylococcus are known as colonizers of the equine skin, contributing to cutaneous infections. There's an increasing threat of antimicrobial resistance and zoonotic potential. Mesenchymal stromal cells have shown promise recently as both regenerative and antibacterial biologics for equine wounds. They are multipotent progenitor cells present in many tissues that secrete bioactive factors, collectively called the mesenchymal cell secretome. Unlike whole mesenchymal cells, utilizing the secretome as an acellular therapeutic for wound healing allows for the use of allogeneic sources. Peripheral blood-derived mesenchymal cells, secretomes in vitro efficacy in promoting tissue repair and inhibiting the growth of bacteria found in cutaneous wounds. Others have studied the in vivo potential of bone marrow and oral mucosal derived secretome for equine wound healing with promising safety and efficacy results. These represent a non-invasive and easily collectible source of cells. The equine secretome collected as conditioned medium in the mesenchymal stromal cell conditioned media is effective against MRSA, both in its planktonic and biofilm forms in vitro. As a biofilm, MRSA is antibiotic tolerant and protected from the host immunity, which contributes to the wound healing. In addition, or lack of wound healing. In addition to its anti-MRSA properties, they found that the equine mesenchymal cell secretome promotes fibroblast migration and angiogenesis in vitro and promotes wound healing in mice. A recent study found that equine thoracic wounds with and without inoculation of bacteria, including Staph aureus, healed more quickly and without complication than the distal rim. All right, so materials and methods. Flunixin, meglumine, and morphine were given as needed. Wound creation with detomidine, butorphanol, xylazine, 4% chlorhexidine scrub, 70% isopropyl alcohol, subcutaneous regional analgesia with an L block, 2% lidocaine, 2% mepivacaine, 6 full thickness excisional wounds measuring 6.25 centimeters square, 2 centimeters apart. They used MRSA for inoculation. It's the strain called FPR3757, acquired from the American Type Culture Collection. And then the number of mesenchymal cells were 75 centimeters squared, or 1.1 times 10 to the 6th mesenchymal cells per flask. For the wound treatment, 24 total wounds, 6 non-inoculated, 6 inoculated per horse. Divide the 3 treatment groups, 2 non-inoculated, 2 inoculated per horse. And then this is a chart they use to describe the wounds that I'll read right now, but in case you want to pause it, that's what they're using to describe the wounds. They're saying for exudate, score is 0, none, 1 mild, 2 moderate, 3 severe. Exudate type, none for score 0, 1 clear, serous, mildly hemorrhagic, 2 mucoid, bloody, 3 purulent and bleeding. Moisture 0, dry, crusty. 1 is slightly moist, 2 wet, mild dripping, 3 very wet and dripping. Scab 0, none, 1 thin, 2 mildly thick, 3 very thick. Granulation tissue 0, none, 1 full granulated, 2 mildly exuberant, 3 moderately severely exuberant. And then for granulation tissue character, 0 non-present, 1 pink healthy flat, 2 dark pink red bumpy, 3 dark red congested fibrous uneven. And then finally for epithelialization, 0 is over 50%, 1 is 25 to 50%, 2 is less than 25% of the wound, and 3 is none. Then for biopsies collected, they did histologic acute infiltration score, which is the sum of the cellular infiltration, how they're clustered, the edema, the bleeding, the necrosis. And then for the histologic repair score, the number of fibroblast proliferation, collagen density, and neovascularization. Okay, for wound inoculation and bacterial culture, inoculated wounds had 3 times more bacterial colony forming units than non-inoculated on day 1, but then no difference per milliliter between inoculated and non-inoculated thereafter. Inoculated and non-inoculated wounds had over 10 to the 5th colony forming units per milliliter during the treatment phase, which is days 1 to 3. Fewer colony forming units per milliliter in the inoculated mesenchymal cell treated wounds than vehicle controlled treated wounds by day 3. And this is a picture of the, oh, you can see it there, here it is. So these are schematics of the different patterns. They're saying here that for this picture here, in section A, bacterial colony formation was 3 times higher in inoculated wound versus non-inoculated on day 1. And then for section B, down here, in these representative images taken at day 3, mupirocin treated tended towards fewer colony forming units in comparison to other treatment groups, and mesenchymal treated towards fewer colony forming unit. Okay, but these had no effects on the treatment on colony forming units per milliliter over time. And then for this picture, you can see the various wounds. Inoculated wounds treated with mupirocin were smaller compared with wounds treated otherwise by day 28. Inoculated wounds healed less, meaning larger wound bed area in comparison with inoculated wounds by day 28. Non-inoculated wound size was not affected by treatment over time. In regards to wound scoring and measurement, as indicated by an overall decrease in wound scores, both inoculated and non-inoculated wounds healed over time at similar rates. No differences were found between the treatment groups for both. It was observed visually that inoculated wounds had more areas of poor quality granulation tissue in the wound bed compared to non-inoculated at day 21, which maybe is caused by bacterial infection. Both inoculated and non-inoculated healed over time based on decrease in wound areas. The inoculated wounds treated with mupirocin were smaller than those treated with mesenchymal or the vehicle on day 28, but not any other time point. Inoculated wounds were larger than non-inoculated. In regards to histopathology, mild to moderate epidermal hyperplasia and granulation tissue were commonly noted based on Mason's trichome staining. So this is this image here for those who want to pause that and who want to look at the histopathology. Acute inflammation, represented as the sum of neutrophilic infiltration, edema, hemorrhage, necrosis, was highest at day 7, irrespective of treatment for both inoculated and non-inoculated. The histology repair, represented by the sum of fibroblast proliferation, collagen density, and neovascularization scores, were also similar between treatment groups as well as between inoculated and non-inoculated wounds. All right, discussion. The inoculation with MRSA on day 0 led to an increase in colony-forming units per milliliter sampled by inoculated wounds the next day. During the treatment phase, 1 to 3, both inoculated and non-inoculated wounds had bacterial loads over 10 to the 5th colony-forming unit per milliliters, which indicates infection. They were saying how they were trying really hard to maintain a sterile environment for the non-inoculated, but clearly something happened there. Previous experiments show that MRSA and other bacteria with equine chronic cutaneous wounds exist primarily as a polymicrobial biofilm. So polymicrobial means more than one bacteria, and biofilm is a combination of bacteria and purulent material and exudate and necrotic cells. The biofilm is a problem because it prevents the host immune system from penetrating and fighting the bacteria. It also prevents antimicrobials from penetrating the biofilm. And then you can imagine if you have an implant that's infected with a biofilm, it proves even more disastrous. Another study concluded that although wound swabs can detect MRSA infection at 2 days after inoculation, tissue biopsies are superior. Biopsies can be used for advanced methods of detection, including next-generation sequencing and peptide nucleic acid fluorescence, in situ hybridization, or confocal laser scanning microscopy for biofilm identification. Clinical indications of biofilm formation, including moisture, poor granulation tissue quality, delayed healing. Inoculated wounds contain more areas of poor quality tissue. For granulation tissue by day 21, they were dark red, congested, and were larger at day 28 compared with non-inoculated wounds, suggestive of slightly delayed healing at this time point and thus potential presence of MRSA biofilms. Mupirocin is known to be effective against MRSA and other gram-negative bacteria. Mupirocin commonly used in humans, and models of other wound healing like in pigs and mice are not used commonly in equine. They did not see any effect on bacterial load and wound healing parameters with equine secretome treatment in this pilot study. The mesenchymal cells that are isolated from the peripheral blood, but there could be other sources of mesenchymal cells like bone marrow and adipose, which are known to have distinct secretome protein profiles. So, they're basically saying that this is just kind of the jumping off point for other studies. They didn't seem to achieve the statistical differences with wound healing, or impacts rather, that they wanted to. But, it is a starting point. So, of course, the problem with a study like this is you want to have larger number of animals. And they mentioned other things here too, like the amount of inoculation, the number of days before you start treatment for horses. Things like that may have affected the results here. So there's definitely room for improvement with the study, which they did clarify here. So for equine practitioners, it looks like mupirocin probably should be used more often in equine medicine for cutaneous wounds. And for pet owners, or horse owners, same thing. Vet triage equine can help with determining these things too. If you have a wound in your horse and we can get triage, mupirocin is something you could potentially get from a veterinarian video call. All right, guys, we'll see you again in the next video. Thanks so much. Bye-bye.